Hello, my name is Howard Beckman. I'm a general internist in Rochester, New York, on the faculty of the University of Rochester School of Medicine and Dentistry, and a senior consultant at Common Ground Health, a health planning agency in Rochester, New York. In the few minutes I have today, I'd like to spend some time focusing on these objectives. I want to help define the spending priorities of the United States healthcare system to determine if it is something that you all should aspire to. I also want to compare the U.S. priorities with those of other selected countries and discuss what the consequences of those policies are. And finally, to suggest approaches to healthcare budgeting that confront healthcare equity and structural racism more effectively in our country and in the world in general. Donald Berwick is one of the healthcare leaders in the quality improvement movement in the United States. And one of the things he says repeatedly is that every system is perfectly designed to get the result it gets. If you look at the United States, the system is based on profit for the pharmaceutical industry, for the hospital industry, for the practitioner community, but not for the general well-being of the population. And I'll show some examples of how the United States compares with other countries in the performance of its public health measures. Dr. Chiara Lapora from Doctors Without Borders has said that if you consider profit to be the endgame of healthcare instead of health, some people will be left out. That has certainly been true in the United States, where there has been a demonstrable disparity in the acceptance of vaccine and in the approach to management of the pandemic. Many upper and middle class workers have been able to work from home, where others of African American and Latino descent have been encouraged to work in the workplace as essential workers. The result is that the pandemic has affected that population in a much more serious way than the white population. This slide depicts the relative contribution of different factors in the wellness of our society. Note that the socioeconomic factors, education, job status, family and social support, income, and community safety, are the major drivers of wellness in our culture. The disparities in these factors, education, job status, income, and community safety, are enormous. The level of community safety has been of recent interest and concern with the advent of video abilities in cell phones, so that people have begun videotaping instances of abuse and inequality in behavior in the police and social service community. This slide demonstrates the impact of racism on the life of the members of our community. African Americans and Latinos are treated differently than white people. The access to health care, the access to jobs, the access to education, the access to neighborhoods are different for different populations and result in disparities in health outcomes that are both disturbing and predictable. I would ask you to think about, in your country, what are the issues that are most relevant in the disparities that exist, and if the disparities are measured and reported to the community as a whole. This slide demonstrates the difference in expenditures. The United States spends significantly more than other populations in other countries, and for which we receive highly technical care, but the populations in general have outcomes that are much worse. And the consequence of that is that the United States performs poorly in quality of care, in coordinated care, in cost-related access, in efficiency and equity. Other countries perform much better and expend much less expense. So the belief that quality is tied to expenditure is not accurate. It's much more important what you do with the money than the amount of money that you. So it's not the total number of dollars that are spent. In the United States, we spend the highest amount of dollars in the world, and for which we receive relatively low or poor outcomes in public health measures, which measure the health of a community. Although we can provide angioplasty for individuals who have a heart attack, the prevention of a heart attack by controlling cholesterol and exercise and diet are much less the focus of attention because they're less profitable than the surgical interventions that are following further down the road of care. It is becoming more clear that the impact of poverty on health is significant. Individuals who are worrying constantly about their ability to survive results in depression and anxiety. The constant focus on physiologic wear and tear of the body and brain results in high blood pressure, diabetes, coronary disease. It's telling that these factors such as housing insecurity, food insecurity, job insecurity, violence and safety are endemic in our culture for a certain percentage of the population, and that we tend to ignore or under-treat these components of our culture and our citizens. And this results in poor mental and physical health and poor outcomes of care. So I think the attention to poverty as a factor, to disparities as a factor, are ones that we are having increasing trouble ignoring and need to spend significantly more attention on. Interestingly, it's becoming increasingly clear in the United States that race is not a biological category. In other words, it's the DNA of an African American is very similar to the DNA of a white person or a Latino. Rather, the social experience of care in the United States and life in the United States is very different for some ethnic groups compared to others. The result is that outcomes of care are more serious in people of color, and that reflects the more the social experience that they've had rather than the biologic experience. This neonatologist in Italy has tried to characterize the disparities that exist in Western Europe and in the United States. We have a health system very well prepared to treat the most complicated diseases, but completely unprepared to fight something like a pandemic or the insurgence of coronary disease, diabetes, obesity in the United States. Over the past decade, health spending increases for specialty care in general, but for primary care is not. And in fact, the public health expenditure for different conditions and the attack on the social determinants of health has been, at least in the United States, significantly underwhelming. People continue to work on the aspects of care that reimburse most significantly, and we continue to struggle with the aspects of life that result in the obesity, hypertension, diabetes that are so endemic in our culture. So what can we do as interested parties in helping those in our society that need help and refocusing on public health rather than profit? These are some of the things that I have thought of. We can explicitly define health equity as a construct of the national healthcare system. So inequity becomes unacceptable, and the healthcare industry is obligated to define ways that offer each citizen or each member of the country a chance to have equal access to care and services. We can confront the notion of profit in healthcare directly. We can reduce low-value care, which I spend a tremendous amount of time working on. We can reduce unnecessary overhead, copycat drugs, and focus on the issues that are deemed relevant to improving the health of the community rather than making money. We can establish the role of poverty on the health of a population quite directly and explicitly, and direct health currency to address the social determinants of health. I think that is something that in the United States we are considering doing, but have been both slow and totally inappropriate in providing. We can build a ground-up network to resolve complicated problems. Atul Gawande wrote a paper in 2013 in the New Yorker called Slow Ideas, where he spent time understanding how a public health solution to a problem in India occurred. It wasn't because the people at the top of the system developed the strategy. It was because people listened to the healthcare workers in the communities and created a solution to a common healthcare problem that was effective. And I think that we could certainly use that level of bottom-up focus. Interestingly, Dr. Berwick described a number of solutions to the systems that we have put in place the healthcare systems we have put in place. He identified what he called stupid rules. And those are, if you ask people in a healthcare system what exists that doesn't make any sense, everybody can tell you what they are. If you can define them and remove them, which are generally easy to do, people respond feeling supported and engaged and come up with more ideas. This can result in significant improvement in practitioner performance. He's defined some of those percentage increases. It can be quite remarkable. Other things that can be done going forward is to improve the role of leadership. And these are simple things that I think each of you can bring home to your country and promote throughout the healthcare community. And they include treating everyone with respect, nurturing a culture where all are welcome and psychologically safe, transparently sharing what you know with a team so that you're not hiding information from them, consistently solicit input from those you lead. That's the Atul Gawande model of seeking input from the ground up rather than the top down. Nurturing and support the professional development and aspirations of staff. I was a chief of medicine at a community hospital in Rochester and found that if I looked at each day having to recruit the people that worked in our department, I created an environment that was much more successful. And finally, recognizing and appreciating the people that you lead. I think offering recognition, praise, and gratitude to people that are working hard every day is a critical step in improving the system. Kate Shanna felt that initially at the Mayo Clinic and now at Stanford has quantitated some of this improvement and said if people adhere to these standards, they increased fulfillment by 11% and burnout decreased by 7%. So these are the opportunities to remove barriers. There's social inequities, structural inequities, living conditions, health behaviors, disease and injury, all influence mortality. And we just don't do a very good job in the United States at working at these things. The health behaviors, the structural inequities, the social inequities are huge and require more attention and work on our part. Finally, it's important that you adhere to models of self-care so that if you're working too hard to improve the lots of others, that you'll sacrifice yourself. And I think that's summed up well in this phrase, you don't have to set yourself on fire to keep others warm. My hope is that you will take care of yourselves as you take care of others, and that this conference will help you accomplish those goals. I appreciate your time and look forward to talking with you later in the meeting during the question and answer period. Thanks for your attention.